welcome to the ID Talk podcast. My name is Tony Bidionis, and I'm here, as I always am, with my good buddy, my good friend, my co-host, and colleague, Mr. Alex Perala. Alex, hello.
Hello, Tony.
Again, sounds like a question, but it's not a question. I can see you right there. We have one of our good pals back on the show today, Mr. J. Meier, Chief Identity Technology Strategist for FaceTec. Jay, welcome back. It's been a couple months since we last chatted with you, and the last time you were here, you talked about healthcare, and we talked about how healthcare's got like a kind of like a bullseye on it. I think maybe were your words, for fraud, and just why it's kind of the next big arena, and something that you guys are going to be focusing on. And I know that you're working on a white paper at the moment, and I know that you are going to be speaking very shortly at the ViVE conference in Los Angeles, I think, in about
That's right.
just a few days, as of the recording date for this. I guess to get us started, before we get into like the tech, what if you could distill it down to like one simplified thing? What's the one thing that we're currently doing wrong when when a patient walks into a hospital?
Well, let's just get the one thing out of the way.
That one thing. Be a real short episode.
Well, thanks for having me back, guys. I know it's been a little while, but I always enjoy these, so it's good to be back yet again.
Us too.
We talked about healthcare last time, and I kind of made a soft announcement that we're going to start pursuing the healthcare market, and not exactly sure. We weren't exactly sure what that meant at the time, but we know that there's some big problems in healthcare that we have specific capabilities that can help solve those problems. Both our standard liveness and our UR code protocol fit very well in the healthcare system in some specific spaces. When a patient, we don't know, the healthcare industry generally doesn't understand if this is actually their patient or it's somebody else standing in as their patient, right? There's a couple of different big issues out there. One is called patient matching, okay? And when we were at Direct Trust, maybe 6 months ago, or maybe it was a year ago, one of the biggest concerns that the people in that healthcare conference had was patient matching. We think this is Jay Meier, right? He's holding Jay Meier's health card. But can we know for sure that this person is in fact the right Jay Meier? Is it the Jay Meier that we think it is? And how do we bind his health record to this event, right? Patient matching, in a way, kind of that has to do with getting the right health record dialed up and lined up for the right patient for some interaction that's about to happen. And it turns out that doesn't always happen smoothly. There's a lot of effort that goes into patient matching because the systems that are in place today don't work very well, right? And some of the byproducts of that are, somebody gets treated for something that they shouldn't have been treated for because they had the wrong file, because they had the wrong patient record. Or some guy, snowbird here in northern Wisconsin, a retiree, he and his wife go to Florida for the wintertime, and they are participating in a different healthcare system down there. And the two healthcare systems don't connect. They're not able to get the right data, the right healthcare records down in Florida. And so they maybe treat him for something that is dangerous in a way when it's in combination with treatments they're getting up in Wisconsin. In other words, drug interactions, there are, other issues out there. So that we are all about binding, right? Binding a human being to a verified identity and then to privileges, usually in this case it would be privilege of getting health care, privilege of providing the health care. The doctor also has a privilege of providing, right? And so we think that imagine if a person wants to call in and schedule an appointment. Well, if you used our UR code, for example, you would know that this is the person. It could be directly linked to the proper health record, and that binding can be established long in advance, right? When that person shows up for that appointment, again, the UR code can be used to confirm that this person is who they claim to be, or who that we think they are, the healthcare system thinks they are, and again, reconfirm that that health record is the appropriate record for this person, right? It reduces duplicity. It reduces redundancy. I read a statistic the other day that said that the average hospital spends 8 to 10 man hours a week just dealing with problems of patient health record, health matching, right? So that's one example, right? And there are other examples. And I'll be quiet for a minute so you can gear up another question.
Yeah, well, you kind of honed in on patient identification, and like there's obviously really serious things that can go wrong there just in terms of health outcomes.
Mm.
But is that also a serious like fraud vector, or is fraud coming from another direction in healthcare?
Oh, it's definitely a fraud vector. I mean, and that kind of gets into the second part. In this white paper that I'm about to publish, it's going to coincide with the ViVE event, right? And so I comment on a couple of different main topics in there and how these technologies can be used to combat these problems. Patient matching is the first, right? The second has to do with credentials, right? Health ID cards, but also health payer ID cards, insurance cards. In the United States, Medicaid, Medicare, VA entitlements, commercial health care payers, the insurance companies themselves for private health insurance. They don't really have a good way of binding that credential to the rightful owner, okay? And that in and of itself represents tens of billions of dollars of fraud in the United States every year. In fact, the problem is so big that they can't even estimate how big it is. You know what I'm saying?
And I'd imagine this isn't something that I never really considered before, because when you hear about fraud in healthcare, as a Canadian, I'll put on my Canadian hat, my toque, if you will, for a second here, but because we have such a different healthcare system up here, my mind usually goes to, it's so much more complex down there because of Medicaid and because of all the insurance that everybody goes through. But there must also be a huge amount of just somebody taking their parents' info and fraudulently presenting that to get access to whether it's drugs or treatment like that. And I mean, I can only imagine how many smaller medical facilities aren't equipped to even know how to.
Right. I mean, there's tens of thousands of healthcare facilities in the United States. Some of them are very big and many of them are very small, right? Many of them serve disenfranchised populations only, and who these people might not have any legitimate, government ID at all, right? And in that case, the medical ID number, the member ID number really is the best they have. So they have no idea if this is actually the right person or not. I don't have any statistics on exactly who and when gets switched up, whether it's but the concept is that somebody other than the rightful entitled recipient takes advantage of the government services, because in a way that they do it by representing themselves as someone they are not. Right. And it's the classic, we've talked about this for years on your pod. It's the same fraud, right? But there is another fraud that is a massive fraud opportunity, and that is in third-party fulfillment of orders. So that would be, pharmacies would be part of that. ordering up a wheelchair for grandma, or some other even at home health care services, delivery, or excuse me, transportation services. Medicaid and Medicare pay for, and many times pay for, third-party transportation. Basically, a little bus that comes and picks you up, takes you to the doctor's office, and then takes you back. Well, Medicare and Medicaid and these systems have no idea if that's a legitimate appointment. They have no idea if the right patient placed the appointment. They have no idea if the service that is supposedly going to come pick you up, right, and take you, what's happening is that there are bogus companies that are submitting claims to Medicaid and for services that they never rendered, never intended to render. There was no patient involved at all, right? It's just a flat out criminal fraud. And that represents billions. I think the Trump administration made a big deal about Medicaid fraud, exactly this kind of fraud in Minnesota, right? Mm-hmm. There was a population of people who were setting up these bogus businesses of medical transportation, and then they would submit for services, for reimbursement for services that they never rendered. And I think that, if I remember correctly, the Trump administration said it was something like $9 billion out of Minnesota alone.
Yeah.
So we talk about that a little bit in the paper, and the idea is that we're in the business of binding, right? So what if you bound the patient, this Medicare, Medicaid recipient, to their card and to the member ID number via the card, right? And when that person shows up for services, they have to actually use that UR code. We can use the UR code to bind them to the card, right? Just print it on the card. It doesn't cost anything. So when that person shows up at the appointment, they can scan their face using the UR code and confirm that they are this person, right? When the bus driver shows up, the person can scan their face and confirm that they are the patient that's supposed to be picked up. And at the same time, the bus driver could be required to scan his face on an employee-style UR code and confirm that he was actually there, because you can use time stamping, you can use all kinds of different technologies to confirm that this person was there. So it locks the two participants in the transaction together at a point in time. And if that was required before reimbursement was provided, most of these frauds would be mitigated in a significant way.
Yeah,
Make sense?
We should zoom out a little bit for anyone listening who, I mean, we've talked a lot about UR codes, but we could have a bunch of people in the healthcare sector who are hearing this and don't know. So maybe, just quickly review for us what do you like, how does someone get their identity like indisputably connected to this code? What does that mean?
Well, let's say that I am enrolled in a healthcare system here, where I live. The health provider is called Asperus, and I get a health ID card. It's digital. I have a digital one and I have a physical one, right? The UR code is a protocol that allows the health provider or some other organization to encode a standardized QR code with verified identity data and a tiny bit of biometric data from the person that credential describes. And then it also provides for a digital signature in the QR code, which means that the QR code can't be adulterated, the data in it can't be adulterated, and you can tell, it tells you who issued the QR code and potentially even if it's valid or not, right? So in this we call it a UR code because it describes who you are. It can be printed on physical documents like a health care member ID card, right? Or it could be printed on physical health record documents, like at the hospital, right? Or it can be attached as a digital asset to a digital record, like a digitized member ID number, or the electronic health record, which is mandated in the United States today, right? So either way, what it does is it irrefutably binds a single person to a single identity and to a single, well, let's just call it a health identity, right? The health, the electronic health record, for example. In the other case, the UR code could be required for the driver of the transportation service. That person gets registered as an employee of this company. They get the UR code, which includes their identity data, some of their biometric data, and a digital signature, which shows who issued it, right? Mm-hmm. And then that person can be required to verify their identity at the point of the service provisioning. So when grandma gets on the bus to go to the hospital, the driver and grandma can each be required to verify their identity right then and there. And that verification can be tokenized, meaning it can be verified, validated that it actually occurred, and it can be timestamped. So guess what? If grandma has the tokenized confirmation and it's timestamped correctly, great. The driver shows up and his identity is verified, the tokenization happens and is timestamped correctly, great. That means the transportation service has auditable documentation and evidence that they actually provided the service. And if you required that evidence when you submitted for reimbursement, Medicaid might be more interested in paying that claim than one that doesn't have that confirmation. Does that make sense?
Yeah. It's setting up a chain of trust.
Yeah. I think we talked about that. The chain of trust, right? We can't trust anybody these days. We can't, either by default, because they just, of no fault of their own, can't identify themselves, or because they're trying to pull a fast one.
So then you're speaking at ViVE, which is a big like health IT security conference, as I understand.
Like 9,000 people are expected to be there.
So how are you actually tackling this? Because there's so many sort of like intersection points in what you're describing. Like who are you trying to get the message out to? Is it like actual healthcare providers, insurers? Like what's the strategy to talk?
It's all of the above. It's all of the above. I mean, there are companies, like there's one big one called Epic, for example, that's based in Wisconsin. Good, yay, Wisconsin. Epic is the biggest provider of electronic health record software systems, right, to hospitals. And if you are in an Epic system and you go an Epic hospital and you go to some other hospital and it also is an Epic hospital, that health identification or that health record is beamed over immediately. They have instant access to the health record, right? But what if they can't tell if it's the right patient? How do they confirm that it's the right patient? That still is a problem out there in some cases. So could the electronic health record vendors, could they use this? I think they could. Any hospital in and of itself that has paper documentation or electronic documentation of interactions with patients, right? Mm-hmm. The hospitals could use this to provide the same audit trails for doctors if they wanted to, or nurses, mm-hmm. right? Who entered this order for this drug? Right. Well, it says that the token says that it was Nurse Kravitz, at this time. So she either gets the promotion or gets fired. The insurance companies, United Healthcare is just this whale of a company, and all they do is provide services around payments and patient documentation. And, if they use the technology, they could implement it easily across any number of different systems and start solving these problems. I wanted to talk originally, and I referenced Medicaid briefly in the white paper, but trying to get the U.S. government to do anything in this case, first of all, nobody at the conference cares about the Medicaid deal because Medicaid pays them. They just want to know that they're going to get their money at the end of the year, right? So they're not worried about that, but the private health insurance companies might be worried about it. And, Medicaid could use this absolutely, but that requires a whole different line of pressure and strategies to make that change. The states that administrate Medicaid would be interested in doing something like that. But, here's another, I gave you this example before, there is a lot of regulation and law about health information security and privacy in the United States. It's a big deal. And so there are specific networks established for the transmission of messages, secure messaging between payers and providers, for example, right? And they use cryptography to ensure the integrity of the data and the movement between, the payer and provider or provider and payer, right? Mm-hmm. And they don't know who actually hit send. They don't know who actually entered the email. It might say it's from Jay, but they don't know if it was actually Jay. Right. And this is a problem for them. It really is a problem in the industry. So the UR code on an employee profile could bind a specific authorized person to the task of submitting a private message to the payer, for example. And then they would have an audit trail that this happened, this person did this at this time. Right. So there's a lot of places.
Yeah, I think you mentioned that to us the last time you were on, specifically the email case and how it just seems to be really opening a lot of people's eyes. And that kind of leads into what I wanted to ask you about. Now, this may not be a question you can answer right now. It might be something that I'm sure it will be something you'll have a much clearer picture of after ViVE next week. But I'm just curious if you're getting a sense of how ready all the different kind of components that make up healthcare are ready for this change, because there's this is slightly pop culture-y, but I don't know if you're familiar with the TV show The Pit. It's a very popular show.
My wife watches it. You guys are young enough. Do you remember a show called ER?
Yeah, Noah Wiley.
The Pit is just ER. Same deal. They're just rehashing that garbage.
One thing that I think I noticed though is I think it's like in recent episodes they're touching on the introduction of technology into the chaos that is like emergency room medicine, and oftentimes a kind of a running theme over, I think it's a couple of seasons now of the show, is just how little time there is to like get to know a patient. You're just kind of dealing with them, especially in like an emergency scenario. So I wonder if the average person is going to start to realize how important that matching is, that just getting the care is one part, but all the other pieces of all the other cogs in the machine, those also have to be working properly. Otherwise, save for a few really crucial examples, it's not going to work out in their best interest in the long run.
The thing about the patient health record, the reason this works so well for patient matching is because you can bind the UR code to the health record, whether it's digital or physical, doesn't matter, right? And with any camera on any smart device, in any operating system, or even on a desktop, you could scan that UR code and then take a picture of that person's face, a live selfie of that person's face and confirm that that is the person that is bound to that health record. Imagine in an ER situation how that could help, right? I mean, and I said that we're looking at this from the perspective of our traditional liveness proven face 3D face biometrics perspective, but also from the perspective of UR codes, right? If one really resides behind the firewall at the hospital, for example, right? What if the hospital bound a 3D face map of every patient to the patient's health record when they enrolled that person, right? And then, the patient walks in and, there's companies that are doing this with fingerprints right now, but they're using big centralized databases and it's not very efficient. And one of them's trying to get sold right now. Who knows why, but, the 3D face matching really lends itself well to this. You can bind the 3D face map to the health record. Let's say that person is brought in an ambulance and is unconscious or can't, respond or doesn't have any ID. The hospital could simply scan their face and find out. They can use our free app, our Scan and Match app. It's available for download right now, folks. If you want to go check it out, they could scan the face and know, that they could scan the UR code on the person's health card and then scan their face and say, yep, this is that person, bring up the health record. Or if the 3D face map was bound to the electronic health record, they could actually scan the person's face and do a one-to-many match on the back end and then know exactly who this is.
Yeah.
Right?
Yeah.
There's so many places that this could start. And then you go into payments, which is sort of a completely different sideshow, but it's that detachment between the payments and the identities where the fraud always exists in between established systems, Right. Does that make sense?
Yeah. And it's a compelling case. So I mean, we saw the response you got when you actually officially announced UR codes at Identity Week, and were chased by a small crowd of people who wanted to learn more. So we hope you get a similar response at ViVE.
Well, when we went to Direct Trust, which is kind of a specialty healthcare deal, it's really about Direct Trust is really about electronic communication between providers and payers and whatnot. But we had the same kind of response. People there were like shocked, like, what do you mean you can do this? Right. And I'm not kidding. That was sort of dipping our toe into healthcare. Let's see what happens. We signed 4 or 5 new customers like right away, and some of them were in secure messaging. Some of them were in health records. Some of them were in other things, So we kind of said, okay, there may be a trend starting here. Let's go to a different kind of conference and see what happens, And I can tell you that, at these conferences, they find out who's going and then people reach out to try and meet with you, right? Mm-hmm. And we've been approached already by several name brand organizations that want to talk specific, not sell us something. They want to talk about our technology, right? Oh, and so we think we're going to have some exciting things happen while we're there.
All right. Well, on that note, let's try and catch up soon after and hear more about how it went. And hopefully we can take a closer look at your white paper as well.
I am at your beck and call. You just let me know and we can talk about anything you want.
All right. Thanks so much, Jay. Break a leg.
Hey, guys. Thank you very much. Talk to you soon.